The next paper is utilizing mobile diabetic foot clinics to provide comprehensive care to patients experiencing homelessness. Chris Bolitz is the presenting author, and senior author Tammy Nguyen from the University of Massachusetts.
Thank you so much for the opportunity to present today. We'll be discussing our project utilizing mobile diabetic foot clinics for patients experiencing homelessness. We have no relevant financial disclosures. Some background, obviously for multiple decades, disparities in PAD outcomes and rate of amputation have been well described and increasingly studied. More recently, Drs. Barshes and Mink published on the importance of shifting the focus from descriptive analysis to identifying at-risk populations and targeted outreach programs for early treatment. This is an example of geographic mapping of rate of amputation for early targeted outreach efforts that were conducted in West Virginia. We saw similar barriers to diabetic foot care in our community. We saw that there was heavy bias for those who can already access hospital services. And while our community certainly has robust services, there was a lack of qualified, comprehensive, multidisciplinary care that we saw in these services, leading to housing insecure patients not receiving adequate care. Our proposed solution was to bring a multidisciplinary medical group to existing community services that focused on providing care for the housing insecure patient population. Our hypothesis was that by organizing a group of multidisciplinary medical volunteers to participate in a mobile diabetic foot clinic for patients experiencing housing insecurity, that's both feasible and sustainable approach to provide comprehensive diabetic foot care in the community. So how exactly did we do this? Our first step was to determine an event venue. We found it crucial to partner with existing community organizations that had services rooted in our patient population of interest of those with housing insecurity. We found that by working with trusted, established community services, we were able to leverage both the infrastructure that these services had and their relationship with the existing patient population to establish our clinics. You can see here on screen left a map of the sites of our 5 clinics that we intentionally spread throughout the Worcester community to serve a diverse group of patients. On screen right, we see the general workflow of our clinics, which begin with registration and vitals, move to testing, including vascular lab testing, move on to foot care, and then end with medical services and donations. Our next task was to find volunteers. These volunteers largely came from our academic medical center with a focus on finding licensed providers to provide care. You can see that over the course of our 5 events from November of 2020 to November of 2022, we've had an increase in volunteer participation. With our increasing volunteer participation and interest in our events, we've been able to expand our services provided from our core services of vascular surgery, podiatry, diabetes, and behavioral health to include ophthalmology and dermatology at our most recent events. Our next step was sourcing supplies and materials, and I think supplies and materials are crucial to these events. Our materials came through a combination of donations, facility and volunteer provided items, and items that were purchased via grant funding. You can see that over the course of our 5 events, the average cost was just under $4,000, and we were able to conduct these again through a combination of grant funding and donations of items such as clean socks and shoes, as you can see on the picture on the left, that were provided to all patients who participated in our clinics. Lastly, and most importantly, we aim to provide quality care to all patients with the opportunity for follow-up. You can see that over our 5 events, we did have variation in participation, and we feel that this was largely a result of location of event, time of year, and additional services being provided at our events. Similarly, the follow-up required at our events varied from event to event based on patient demographics. And for follow-up, we found this was crucial to occur. We had the opportunity for all patients to enroll in Medicaid at the time of our event for follow-up, and all providers at our events committed to providing follow-up at our academic medical center if needed. So our lessons learned, I think there were many. We found that a mobile diabetic foot ulcer clinic targeted at unstably housed patients is feasible, and vascular surgeons are well suited to organize these events within the community. A robust group of volunteers with varied backgrounds is required for a successful event, but volunteer interest is high within an academic medical center. And lastly, that partnering with existing community organizations is crucial, as are donations and grant funding. Thank you so much, and happy to answer any questions.
Excellent. So as I understand it, these were free clinics, and I think an excellent process to provide care. But I wonder if as evident by the lack of follow-up, if this can be extended and modified to a degree to improve care for patients who are otherwise can obtain insurance, whether Medicaid or Medicare, and if resources can be modified using the resources that you have to expand the care to allow it to become more long-term rather than just episodic.
Sure, yeah, thank you so much for that question. I think, to your point, one of our focuses certainly was the opportunity for follow-up care. I think our follow-up data partially does reflect the fact that these efforts were both to identify patients with existing health conditions and to also kind of serve as early preventative treatment. So a number of patients just we felt didn't require follow-up as they didn't have an issue requiring follow-up, and I think there's been good data to demonstrate that early preventative exposure to these conditions is beneficial, but I think certainly combining that with care at an academic center is important.
Dr. Humphries.
You called it a diabetic foot clinic that had been, but at the end of the slide it said diabetic foot ulcers, and I might have missed a little bit of that, but how many of these patients did have wounds, and what did you do to help them to get wound care, or how did you connect them in some way?
Sure. We had, I think roughly about 10 or 15% of patients were found to have diabetes. Roughly that same amount of patients were found to have some sort of skin lesion at the time of the event. We were able to provide a certain amount of care at the event, so we had podiatry colleagues, nurses from our wound clinic at the event, and so any care that we felt was appropriate to occur at the clinic, we performed at the clinic. Obviously, for a number of these issues, so with our podiatry colleagues, things like foot x-rays are obviously important, and we didn't have that service at our clinic. And so to that end, we did provide the opportunity for follow-up for all of those patients. In Massachusetts, we're fortunate enough that most of these patients qualified for Medicaid, and we could enroll them at the time of our event. And our podiatrists at the event were those at our academic center, so they saw them in follow-up.
Excellent job.
Great.
Thank you.
Thank you.